Bismillahirrahmanirrahim. Good day, everyone. Today we will discuss a practical and clinical relevant case, diarrhea in long-term kidney and pancreas transplant recipient. Using real-world case scenario, we will review the differential diagnosis, key diagnostic clues, and common pitfalls, and the evidence-based management strategies that can be directly applied in daily clinical transplant practice. I'm Dr. Mahmoud Sheikh, nephrology consultant and World Kidney Academy educator. So let's get started. Let's start with a brief overview of this patient. This is a 35-year-old woman who underwent kidney-pancreas transplant approximately 7 years ago for end-stage kidney disease, secondary to diabetic nephropathy. She has been doing remarkably well from a graft standpoint, with a stable kidney function and no major transplant-related complications for several years. The reason she came to medical attention was 2-month history of persistent diarrhea. Now, in general population, chronic diarrhea is common, often benign. However, in a long-term transplant recipient, it immediately raises a much broader differential diagnosis. At this point, we need to think beyond routine GI causes and consider issues that are unique to transplant patients, including opportunistic infections, medications toxicity, alteration in immunosuppression exposure, and even the possibility of allograft-related consequences. So the key questions become: what's driving the diarrhea, and more importantly, what the implications for the transplant kidney and pancreas? That's the clinical challenges we are facing in this case. At first glance, this may seem like a pretty straightforward complaint, just chronic diarrhea as we mentioned. But in transplant recipient, things are rarely that simple. This patient is 7 years out from kidney pancreas transplant and has been relatively stable. The problem is that she's now reporting 2 months of ongoing active diarrhea. And whenever I hear that story in a transplant patient, as we mentioned, this is one of the few red flags immediately goes up. If this infections, if this medication-related issue, if this diarrhea affecting immunosuppression absorption, or is clue to something bigger happening beneath the surface? Those are questions we will try to answer as we move through this case. Before we dive deeper in the current illness, it's important to understand the patient's baseline. This was not a patient with isolated diabetic kidney disease. She had evidence of long-standing advanced diabetes affecting multiple organ systems. She had diabetic nephropathy, which ultimately progressed to end-stage kidney disease and led to transplantation from the start. And she also had diabetic retinopathy, reflecting significant microvascular involvement beyond the kidneys. In addition, she had mild autonomic neuropathy, suggesting that the nervous system had already been affected by years of diabetes. And notably, she had gastroparesis and manifestation of diabetic autonomic dysfunction involving the GI tract. Prior to transplantation, she also carried history of hypertension and chronic headaches. Why is this relevant in our case? Because some of these complications, particularly autonomic neuropathy and gastroparesis, can continue to influence GI symptoms even years after transplantation. So, as we evaluate her current presentations with chronic diarrhea, we need to keep in mind that not every GI symptom in a transplant recipient is necessarily infections or medication related. The patient's underlying diabetic autonomic dysfunction may still be a part of the whole story. And before we get into the current problem, let's briefly review her initial immunosuppressive strategy at the time of transplantation. Like many kidney transplant recipients, she received relatively potent induction regimen consisting of ATG along with high-dose methylprednisolone. The goal of induction therapy is to provide intense immunosuppression during the highest risk period for acute rejection, which is the immediate post-transplant phase. Thymoglobulin achieves this through profound T cell depletion, while steroids provide rapid, broad suppression for the inflammatory response. This approach has been widely used in simultaneous kidney-pancreas transplantation because of historically higher immunological risk associated with these recipients. Importantly, there were no reported early rejection episodes following transplantation, suggesting that the initial immunological control was very successful. So from the outset, this patient achieved excellent graft stability, which makes her current presentation several years later particularly interesting. Now, if we have taken care of transplant patients for any length of time, this maintenance regimen probably looks very familiar. Prednisolone, Tacrolimus, and MMF, pretty standard stuff. For years, this did exceptionally well on this combination: no rejection, stable graft function, no major complications. But here's where things start to get interesting. When a transplant patient walks into clinic with 2 months of diarrhea, one of the first things that pops into your mind isn't necessarily infection It is the medication list. And whenever MMF is sitting there on the chart, we have to wonder whether the drug itself is a part of the problem. That possibility is going to follow us throughout the rest of our case presentation. Let's briefly review her CMV history. At the time of transplantation, the patient was CMV IgG positive and EBV IgG positive, indicating prior exposure to both viruses. Based on her risk profile, she received Valgan cyclovir prophylaxis for 3 months following transplantation. At that point, everything followed a fairly routine post-transplant course. Now, why this detail is important? Because whenever a transplant recipient presents with prolonged diarrhea, CMV immediately enters the differential diagnosis. And that's true even years after transplantation. While the risk is certainly highest during the first several months after transplant, late CMV disease still occur, particularly when there are changes in immunosuppression or other factors that alter immune surveillance. So, although this patient has received appropriate prophylaxis, CMV couldn't simply be dismissed on the basis of timing alone, as we will see later. That possibility still required careful evaluation. One detail in her transplant history that immediately caught my attention was her early experience with MMF. Shortly after transplantation, she was receiving the standard dose of 1 gram twice daily. However, she developed GI intolerance, primarily nausea and epigastric discomfort. Rather than discontinuing the medication, the dosing schedule was modified to 500 mg 4 times daily while maintaining the same total daily dose. Interestingly, her symptoms resolved following that adjustment. Now, why is that important? Because it tells us that this patient has already demonstrated GI sensitivity to MMF very early in her post-transplant course. At the time, the problem appeared manageable and responded to relatively simple dosing modification. But looking back, it raises an important question. Could MMF once again be contributing to her current GI symptom years later? At this stage, we don't know the answer, but this historical clue is difficult to be ignored. And we will see it becomes increasingly relevant as the case unfolds. So despite excellent graft function and overall clinical stability, there was already documented history of MMF-related GI intolerance. The question now is whether her current presentation represents something entirely new or whether we are seeing a much later manifestation of a problem that had been present all along. Before the onset of her current illness, the patient had been remarkably stable for years. Her kidney allograft function was excellent, with the baseline serum creatinine consistently ranging between 1.1 to 1.3 mg per deciliter. Tacrolimus exposure was also stable, with trough level maintained within target therapeutic range of approximately 7 to 8 nanogram per millimeter. Equally important, the pancreas graft was functioning well. She remained completely insulin independent with normal glycemic control and no evidence of pancreatic graft dysfunction. So when we step back and look at the big picture, there was not a patient with struggling graft, fluctuating immunosuppression, or progressive chronic allograft dysfunction. Quite the opposite. She had achieved what we hope to see long-term kidney pancreas transplantation, stable graft function, durable pancreas graft function, and excellent metabolic control. That's what makes the development of resistant diarrhea particularly concerning in this patient. This issue wasn't occurring in the setting of gradually declining transplant. It was disrupting an otherwise very successful and stable post-transplant course. So after years of clinical stability, the patient suddenly developed new GI complaint that persisted for nearly 2 months. Let's take a closer look how these symptoms began and how they evolved over time. Now we arrived at the problem that brought the patient to medical attention. Approximately 2 months before presentation, she began experiencing persistent loss in bowel movement. What's notable is not just the presence of diarrhea, but the absence of many of the features that would normally point us toward specific diagnosis. She denied abdominal pain, she had no nausea and vomiting, there was no fever, chills, and no other systemic symptoms to suggest an acute infectious process. There was no recent travel history, no new medications had been introduced, and no household contacts were experiencing similar symptoms. So, right from the beginning, this presentation was somewhat unusual. The diarrhea was persistent but lacked many of the clues we typically rely to narrow the differential diagnosis. At this stage, the possibilities remain broad. Could this still be an occult infection? Could this represent medication toxicity? Could this be related to underlying GI pathology? Or could it reflect a transplant-specific complications that had developed years after an otherwise successful transplant? At this point, we really don't know. But what we do know is that the symptom persisted for 2 months without a clear explanation, and that persistence is what ultimately triggered a more comprehensive evaluation. Given the duration of symptoms in her transplant history, the next step was a systematic workup to exclude the common infectious and non-infectious causes of chronic diarrhea in an immunosuppressed patient. Given her transplant history and the persistence of symptoms, the initial evaluation focused on ruling out the most common infectious causes of chronic diarrhea, and that's where the case started to become more challenging. Stool studies were negative for bacterial pathogens as well as Giardia. Testing for CD-T toxin was also negative. Because viral infections remain an important consideration in immunosuppressed patients, she underwent testing for both norovirus and adenovirus, and those studies were negative as well. In parallel, cross-sectional imaging with CT scan was performed, showed no significant abnormalities. So at this point, the usual suspect had largely been excluded. There was no evidence of bacterial infection, no evidence of common enteric viral pathogens, no evidence of CDT, and no structural explanation on imaging. And this is really the point in this case where the differential diagnosis begins to shift. When the routine infection workup comes back completely unrevealing, we have to start thinking beyond common pathogens and consider less obvious possibilities, including medication-related toxicity, occult gastrointestinal disease, and transplant-specific complications. Despite 2 months of symptoms, every major test performed so far was negative. So the next question became, if this is not infection and imaging is unrevealing, what else could be driving this diarrhea in such patients? At this point, given the negative infectious workup, attention naturally shifted toward one of the most common non-infectious causes of diarrhea in transplant recipient, MMF. The patient had already demonstrated GI intolerance to MMF earlier in her post-transplant course, so reducing the dose was very reasonable, the next step. Her MMF dose was decreased from 500 milligrams 4 times daily to 500 milligrams twice per day. If MMF toxicity were the primary driver, we would typically expect at least some degree of symptomatic improvement. But that's not what happened. The diarrhea persisted without any meaningful change. In fact, the patient continued to experience 5 to 6 loose bowel movements per day and ultimately lost approximately 10 pounds. That lack of response is an important turning point in such case. Because once symptoms persist despite significant reduction in MMF exposure, we have to start questioning whether we are dealing with something more than simple medication intolerance. Now, MMF-related toxicity wasn't completely excluded in this stage, but it was becoming increasingly difficult to attribute the entire clinical picture to the drug alone, and that's what pushed the evaluation toward a deeper search for alternative explanation. So now we have a patient with chronic diarrhea, progressive weight loss, negative infectious workup, normal imaging, and no meaningful response to MMF dose change. At this point, the next step was to take a closer look at the rest of her medications, reassess the entire clinical picture. It's worth taking a step back and carefully reviewing her medication profile. As we mentioned, one of the most important lessons in transplant medicine is that the medication list is often a part of the diagnosis. Her immunosuppression regimen consists of prednisone 5 mg daily, Tacrolimus 3 mg twice daily, and MMF, which had already been reduced to 500 mg twice daily because of concerns about gastrointestinal toxicity. She was also receiving several non-immunosuppressive medications, including telmisartan with hydrochlorothiazide, famotidine, rosuvastatin, low-dose aspirin. What's striking here is that there had been no recent medication changes, no newly introduced drugs, no recent antibiotics, no obvious pharmacological trigger that could really explain the onset of this diarrhea. And that's an important observation because when medications-induced diarrhea occurs years after a patient has been stable on the same regimen, the diagnosis becomes much less straightforward. At this stage, MMF remains suspect, but the case is no longer fitting the classic pattern of simple drug intolerance. The patient had tolerated this regimen for years. Her infectious evaluation was unrevealing. Her symptoms persisted despite dose reduction. Thus, the question becomes, we are dealing with an atypical manifestation of drug toxicity, or is there something else we are still missing? With the history reviewed, the medication list reassessed, and the initial workup proving unrevealing, the next step was to look more closely at the patient physical finding and search for clues that might help narrow the differential diagnosis in this case. At this stage, the physical examination offers surprisingly few clues. The patient was febrile, making an active systemic infectious process somewhat less likely. Her abdominal examination was essentially benign. There was no tenderness, no peritoneal signs, no focal finding to suggest an inflammatory or structural gastrointestinal disorder. The one notable abnormality was a modest orthostatic drop in systolic blood pressure of about 10 millimeters of mercury. Taken in isolation, that finding may not seem particularly dramatic, but in context of 2 months of ongoing diarrhea, it becomes clinically meaningful. It suggests that the patient has beginning to experience the physiological consequence of chronic fluid and electrolyte loss. And that's really the key message from this slide. The examination wasn't pointing us toward specific diagnosis, but was confirming that the diarrhea was real, persistent, starting to have measurable systemic effects. So despite an unrevealing workup and relatively normal physical examination, this was no longer a minor symptom. It was becoming a clinically significant problem. At this point, we had a patient with chronic diarrhea, with loss, early loss, signs of volume depletion, negative infectious blood studies, and no clear explanation. The next step was to look more closely at the lab data and see whether the blood work could provide clues that the history and examination had not. Now, this is where the case started to become much more interesting. The lab finding tell a story that the physical examination only hinted at. First, her serum creatinine has increased from baseline to approximately 1.2 up to 1.5 reduced later. That's not dramatic rise, but in transplant recipient with previously stable graft function, even a modest increase deserves attention. Importantly, after volume repletion, the creatinine returned to baseline, suggesting that volume contraction from ongoing GI loss was a primary driver rather than intrinsic allograft injury. The bicarbonate level was 18, consistent with the metabolic acidosis and exactly what one would expect in setting of prolonged diarrheal losses. Potassium was also trending low at 3.5, again supporting ongoing GI potassium wasting. But perhaps the most revealing finding was that Tacrolimus level. Historically, her trough has been stable around 7 nanograms per milliliter. Now they had increased to approximately 13 nanograms per milliliter, despite no intentional change in the dosing. And that's a classical transplant teaching point. Severe diarrhea can paradoxically increase tacrolimus exposure by altering intestinal metabolism and drug transport mechanism, leading to unexpectedly elevated levels. So at this stage, the lab data are internally consistent. They point toward a patient with significant chronic diarrhea causing volume depletion, metabolic acidosis, potassium losses, and altered tacrolimus pharmacokinetics. What they don't provide is the underlying diagnosis. The labs are telling us the consequences of disease process, but not yet the cause. So despite mounting evidence that the diarrhea was physiologically significant, we still lacked a unifying diagnosis. The next challenge was deciding where to go from there and which possibilities remained most likely after an otherwise unrevealing workup. At that point, the case has reached an important crossroads. The patient has persistent diarrhea for 2 months, progressive weight loss, evidence of volume depletion, and largely unrevealing non-invasive workup. When you find yourself in that situation, the next logical step is to obtain tissue. Colonoscopy was therefore planned not simply to look for visible abnormalities, but to obtain biopsies that could identify processes that are often missed by stool studies and imaging. Several possibilities remain on the table. Could there still be same E. colitis despite negative initial testing? Could we be dealing with an inflammatory colitis? Could be there a medication-related injury that only histology could reveal? Or less likely, but still importantly to exclude, would this represent a malignancy such as post-transplant lymphoproliferative disease involving the GI tract? At this stage, the different diagnoses remained broad, but the investigation was becoming more focused. The hope was that endoscopic evaluation would finally provide the missing piece of puzzle. So after weeks of symptoms and an otherwise unrevealing evaluation, the colonoscopy became the pivotal diagnostic test, the moment where we would either confirm one of our leading suspicious causes or uncover an entirely unexpected new diagnosis. Let's pause here for a moment and think through the different diagnoses together. Based on everything we have seen so far, what's the most likely explanation for this patient's diarrhea? Could this simply be diabetic nephropathy related to her long-standing autonomic neuropathy? Could this be simply MMF toxicity despite years of apparent tolerance? Should we still be concerned about CMV colitis even with a negative initial infectious workup? Or are we dealing with something more ominous, such as GI malignancy and post-transplant lymphoproliferative disorder? At first glance, several of these options seem logical, but if we carefully review the clues, one diagnosis begins to move towards the top of the list. The patient prior history of GI intolerance to MMF, Her infectious studies have all been negative. The pattern of diarrhea is chronic and non-inflammatory, and importantly, the evaluated elevated Tacrolimus levels suggest significant intestinal injury affecting drug handling and absorption. So before we see the colonoscopy finding, the leading hypothesis in this point would probably the MMF-associated GI toxicity. That said, there is no major problem with jumping to that conclusion. The symptoms persisted despite MMF dose reduction, and that's exactly why this case remains interesting all the track. The diagnosis may seem obvious, but we still need objective evidence before we can be confident we are right. At this stage, the leading diagnosis is MMF-associated gastrointestinal toxicity, and in many ways, the case has been quietly pointing us in that direction from a very beginning. MMF is one of the most common cause of chronic diarrhea in transplant recipients and remain a frequent reason for dose reduction or drug discontinuation. Several clues support the diagnosis. The patient has a prior history of GI intolerance to MMF. Shortly after transplantation, the infectious evaluation was intensive and unrevealing. Imaging was normal. There was no convincing evidence for CMV disease, malignancy, and other systemic process. And the elevated Tacrolimus level provided an additional clue that significant intestinal injury was affecting drug handling within the gastrointestinal tract. Now, one of features of this case deserves special attention. Many clinicians expect MMF toxicity to occur shortly after starting therapy, but that's not always the case. Patient can occasionally develop significant GI toxicity years after transplantation, despite having previously tolerated form of medication. That's why medication toxicity should never be dismissed solely because the patient has been on drug for a long time. That said, this diagnosis is still a working hypothesis. The real test is whether we can obtain objective evidence to support it. And that's exactly where the colonoscopy and biopsy finding become critical. So we now have our leading suspect. The next question is whether the endoscopic and histological finding will confirm that suspicion or force us to reconsider the entire differential diagnosis. Before we move forward within the biopsy finding, I'd like to pause for a moment and step back to look at the broader framework we use when evaluating diarrhea in transplant recipient. One of the biggest mistakes we can make is anchoring too early on a single diagnosis. In reality, the differential diagnosis is much broader, and that's the general population. First, we always have to consider infectious causes that include bacterial pathogens, CDT, CMV, norovirus, fungi, and variety of parasitic infections. And among of these, norovirus deserves special attention because it can cause severe, prolonged, and sometimes debilitating diarrhea in immunosuppressive patients. Second, we need to think about medications. And in many transplant clinics, medications are actually among the most common causes of chronic diarrhea. MMF is the classic culprit, but Tacrolimus and mTOR inhibitors can also be contributing factors. Third, we have to remember malignancy. Although uncommon, PTLD and other GI malignancies can occasionally present with chronic diarrhea from the start and weight loss. And finally, there are metabolic and functional causes, including diabetic enteropathy, autonomic dysfunction, and small intestinal bacterial overgrowth. The key takeaway of that transplant-associated diarrhea is rarely a diagnosis made by intuition alone. It requires a systemic approach, ruling out infection, reviewing medications carefully, considering malignancy when appropriate, and pursuing endoscopic evaluation when the diagnosis remains unclear. That's exactly the process we have followed in this case. So after systemically working through much major category and narrowing the differentials, the next step was to see whether the endoscopic findings could finally identify the true culprit behind the symptoms. One of the most important questions in this case is not why MMF toxicity is possible, but why CMV colitis became increasingly unlikely. And there are several reasons for that. First, let's consider the timing. CMV is certainly not restricted to the early post-transplant period, but the highest risk is typically during the first several months, and in many cases, within the first 1 to 2 years after transplant. Our patients is 7 years out from transplant and making CMV substantially less likely, although not impossible. Second, her serological profile was relatively reassuring. She was CMV seropositive before transplantation, meaning she already had pre-existing immunity. The highest risk scenario is usually a CMV seronegative recipient receiving an organ from seropositive donor. That was the situation here. And third, the clinical picture simply didn't fit particularly well. She had 2 months of ongoing diarrhea, but no fever, no constitutional symptoms, and no leukopenia. Now, none of those findings are required for CMV colitis, but their absence makes the diagnosis progressively less convincing. So when we put all of these pieces together, CMV remained on the differentials, but it was gradually moving lower on the list. Importantly, though, In transplant medicine, we don't exclude CMV based on probability alone. We exclude it based on objective evidence. And that's exactly why tissue diagnosis and histological evaluation remain essential before we could confidently move away from CMV as an explanation. So if the clinical picture wasn't strongly supporting CMV, the next question became whether there was another serious diagnosis we still needed to rule out before settling on a medication-related toxicity or not. Another diagnosis that deserves consideration in any transplant recipient with chronic diarrhea and weight loss is lymphoma, particularly post-transplant lymphoproliferative disease or PTLD, and honestly, this is exactly the type of diagnosis we don't want to miss. But when we look closely at this case, several features argue against it. First, the patient has no abdominal pain, no other symptoms suggesting a mass lesion or infiltrative gastrointestinal process. Second, cross-sectional imaging was unrevealing from the start. There was no lymphadenopathy, no bowel mass, and no radiological evidence of lymphoproliferative disorder. Third, post-MPA and EBV PCR testing were negative, while PTLD can occasionally occur without detectable EBV viremia, and negative viral studies certainly make the diagnosis less compelling. And finally, LDH was not elevated, providing one more piece of evidence against highly proliferative malignant process. Now, none of these findings completely exclude lymphoma, but medicine is about probabilities. And when we combine clinical presentations, lab data, and imaging finding, lymphoma becomes considerably less likely than a medication-related GI injury. So at this point, PTLD remains a theoretical possibility, but it's no longer one of our leading diagnostic considerations. Having systemically worked through infection, malignancy, and other transplant-specific complications, we are left with a diagnosis that increasingly fits both timeline and clinical pictures. The next question is whether diabetic enteropathy could still explain the symptoms or whether the evidence continues to point toward MMF-related GI toxicity. At this stage, another reasonable alternative diagnosis is diabetic enteropathy. After all, the patient underwent pancreas transplantation because of long-standing diabetes, and diabetic autonomic dysfunction can certainly cause this form of chronic diarrhea. However, several aspects of the case make diabetes enteropathy much less convincing. First, there was no prior history of enteropathy. The patient has been symptom-free for years after transplantation. Developing severe diabetic enteropathy for the first time 7 years after would be unusual. Second, the pattern of weight loss doesn't fit particularly well. Diabetic enteropathy can cause chronic diarrhea, but substantial unintentional weight loss should always prompt us to look to another explanation. Third, the timing is important. Following successful pancreas transplantation, glycemic control had normalized. Insulin was no longer required. The pancreatic graft function remained excellent. In that setting, progressive diabetic autonomic GI dysfunction becomes less likely. Most importantly, diabetic enteropathy would not explain why the diarrhea persisted despite a negative infectious workup, yet eventually improved when the immunosuppressive regimen was modified. So while diabetic enteropathy remains part of the differentials, the overall clinical picture doesn't strongly support it. And instead, the evidence continues to point toward a medication-related GI toxicity. Once infection, malignancy, and diabetic enteropathy have been carefully excluded, we arrive at the central question of this case. How can we confidently establish MMF as a culprit, and what evidence ultimately confirmed the diagnosis in such case? At this point, the diagnosis process became one of exclusion and confirmation because the patient was immunocompromised. We remained concerned about occult infection and post-transplant malignancy. First, CMV and EBV PCR testing were obtained and both returned negative. This significantly reduced the likelihood of CMV colitis and PTLD, as we mentioned. Second, LDH were normal while not diagnostic, and elevated LDH is commonly seen in aggressive lymphoproliferative disorder, so a normal value further weakened the lymphoma hypothesis. Third, colonoscopy was performed. Importantly, there was no evidence of inflammatory colitis, CMV-associated disease, mass lesions, or any alternative structural explanation for this diarrhea. At this stage, the major competing diagnosis has been systemically excluded. The infectious workup was negative, as we mentioned. The malignancy evaluation was unrevealing. The endoscopic assessment doesn't identify another cause. What remained was a diagnosis that best fit the clinical timeline, the medication exposure, and the overall pattern of disease, MMF-related GI toxicity, but late form. This is a classic example of how drug toxicity in transplant medicine is often diagnosed of careful exclusion rather than a single positive test. Once the diagnosis was established, the next challenge became management. The question was no longer what's causing the diarrhea, but rather how can we control the toxicity while preserving adequate immunosuppression and protecting both graft and patient. Now that we have established MMF toxicity as the most likely diagnosis, the next step is management. This is where transplant medicine becomes particularly challenging. The goal is not simply to stop diarrhea, the goal is to relieve symptoms while maintaining adequate immunosuppression and protecting both the kidney and pancreas grafts. Let's examine these options. Option A, loperamide may reduce symptoms temporarily but doesn't address the underlying cause. Option B, lowering the MMF dose has already been attempted. The dose was reduced substantially, yet the diarrhea persists and weight loss continued. Option C, discontinuing MMF altogether with continuing only tacrolimus and prednisolone would eliminate the offending drug, but at the cost of reducing longer-term immunosuppressive protection, particularly in pancreas transplant recipient. Option D, switching from MMF to azathioprine offers an alternative anti-proliferative agent while maintaining triple drug immunosuppression exposure. So the question becomes, should we continue struggling with a drug that is clearly causing toxicity, or should we replace it with an effective alternative that preserves graft protection while resolving symptoms? Take a moment to decide before the revealing answer in your head, and we will reveal it at the end. Let's see which option provides the best balance between symptom control and preservation of long-term graft dysfunction. Among the available options, the best management strategy is to switch from MMF to azathioprine. Why? Because the patient has already undergone meaningful dose reduction of MMF, yet the diarrhea persisted, weight loss continued, and the quality of life remained significantly affected. At that point, simply lowering the dose further would risk under immunosuppression without guaranteeing symptom improvement. Likewise, symptomatic treatment with antidiarrheal agents may reduce stool frequency but doesn't eliminate the underlying drug toxicity. Complete withdrawal of MMF without replacement is also undesirable, particularly in a patient with both kidney and pancreas transplant, because it reduces the intensity of maintained immunosuppression. Azathioprine provides an effective alternative anti-proliferative agent. It allows removal of the offending drug while preserving three-drug immunosuppressive strategy and maintaining protection against rejection. This is a practical principle in transplant medicine. When a drug toxicity persists despite dose reduction, the preferred strategy is often substitution rather than simple discontinuation. The objective is also to balance toxicity against rejection risk. Not every adverse event effect requires abandoning a drug class altogether. Sometimes the optimal solution is replacing a poorly tolerated agent with an alternative that delivers similar immunosuppressive efficacy with better tolerability. The real question, however, is whether this strategy actually worked in our patient or not. Let's look at what happened after the conversion from MMF to azathioprine and examine the clinical response over the following weeks. This slide provides the most convincing evidence that our diagnosis was correct. In medicine, we often talk about the concept of a therapeutic challenge. If symptoms improved after removal of suspected offending agents, confidence in the diagnosis increased substantially. That is exactly what happened here. After MMF was discontinued and azathioprine was introduced, the patient diarrhea began to improve within a matter of weeks. The frequency of bowel movement progressively decreased, hydration status normalized, and overall GI symptoms improved significantly. Even more importantly, the patient regained most of the approximately 10 pounds that had been lost during the illness. Weight recovery is a particularly important endpoint because it reflects true clinical improvement rather than temporary symptoms suppression. This response strongly supports MMF associated as a primary driver of the patient's symptoms. Has the diarrhea been due to CMV colitis, PTLD, diabetic enteropathy, or another structural GI disease, we would not expect much dramatic improvement simply from changing the anti-proliferative immunosuppressive agent. The clinical response therefore served as a real-world confirmation of the diagnosis. So, in drug-induced disease, improvement after withdrawal of suspected medication is often one of the strongest pieces of diagnostic evidence available. The case naturally raises another important question. Why does MMF cause diarrhea so frequently, and what mechanisms are responsible for its GI toxicity? Understanding that pathophysiology helps us to recognize similar cases much earlier in clinical practice. Before discussing toxicity, it's important to understand why MMF mycophenolic acid becomes such a cornerstone of modern transplantation. Mycophenolic acid, or MPA, is the active metabolite of both mycophenolate mofetil or enteric-coated mycophenolate sodium. Its mechanism of action is highly specific. MPA reversibly inhibits inosine monophosphate dehydrogenase, commonly known as IMPDH. This enzyme is essential for de novo purine synthesis, the pathway lymphocytes used to generate nucleotides required for proliferation. Activate TMB lymphocytes are particularly vulnerable because they rely almost exclusively on this pathway and have limited ability to use alternative salvage pathway. As a result, MPA selectively suppresses lymphocyte expansion while having relatively less impact on many other cell types. This selective inhibition is one of the reasons MMF became a key component of maintenance immunosuppression in kidney, pancreas, liver, heart, lung transplantation. In clinical practice, MPE significantly reduce acute rejection rates, improve long-term graft outcomes, which explains why it remains one of the most commonly prescribed immunosuppressive agent worldwide. The same mechanism that make mycophenolate highly effective against lymphocytes also explains many of toxicities. Tissues with rapid cellular turnover, particularly the GI epithelium, may become unintentionally targets of antiproliferative effects. This leads us to next question. If MMF is so selective for lymphocytes, why is gastrointestinal toxicity so common, and what exactly happens at the level of intestinal mucosa? Now, with this, we have reviewed the mechanism of action of mycophenolic acid. An important practical question arises: if MPA is an active drug, why do we have different formulations? The answer is that MPA itself is poorly absorbed when administered directly. Therefore, it's delivered as one of two prodrugs. The first is mycophenolate mofetil, or MMF, commercially known as Silcept. After absorption, MMF is rapidly converted to active mycophenolic acid. The second is enteric-coated mycophenolate sodium, or commonly known as Myfortic. This formulation is designed to delay dissolution until the drug reaches small intestine. Historically, this Myfortic was developed with the hope of reducing upper gastrointestinal intolerance. However, both formulations ultimately generate the same active metabolite MPA. More importantly, both expose the intestinal mucosa, particularly the small intestine and colon, to biologically active drug. As a result, the risk of lower gastrointestinal toxicity, including diarrhea and colitis, remains present with either formulation. This is critically clinical pair. Switching from MF to Myfortic may improve dyspepsia or upper GI symptoms in some patients, but it doesn't reliably eliminate MPA-associated diarrhea. When a transplant recipient develops severe MPA-induced diarrhea, simply changing from Silcept to Myfortic is often insufficient because the underlying toxic molecule remains exactly the same, which is MPA. This raises the next question: if both formulations generate the same active compound, what is the actual mechanism behind MPA-induced diarrhea and chronic injury? One of the most fascinating aspects of MPA toxicity is that it doesn't always behave the same way. In fact, MPA-associated diarrhea can present in different clinical patterns depending on when it occurs and how severe the intestinal injury becomes. The most common scenario is early post-transplant diarrhea. This usually develops within the first month after transplantation when patients are receiving higher levels of immunosuppression. In many of these cases, symptoms improve after a modest reduction in MPA dose. Second pattern is late-onset diarrhea. This is less common but clinically very important. This is our case. Patients may remain completely stable for years and then suddenly develop chronic diarrhea, weight loss, and evidence of intestinal injury. These patients frequently require complete withdrawal of MPA and substitution with an alternative antimetabolite such as azathioprine. Our patients belong to this third category. She developed severe persistent diarrhea many years after transplantation, failed a 50% dose reduction, and ultimately required drug substitution. The timing of MPA toxicity is unpredictable. The absence of gastrointestinal symptoms during the early post-transplant period doesn't protect a patient from developing clinically significant MPA enterocolitis years later. Many clinicians incorrectly dismiss MPA toxicity when symptoms occur several years after transplantation. However, late-onset MPA enterocolitis is well recognized entirely and may present even after prolonged periods of stable therapy. If late-onset disease can occur years after transplantation, the next question becomes, why does this happen, and what makes some patients develop toxicity despite long-term intolerance? At this point, it may seem straightforward. If MPA is causing diarrhea, why not simply reduce the dose or stop the drug? The answer is that MPA is one of the major pillars of maintenance immunosuppression, and that creates an important therapeutic dilemma. Multiple studies have shown that reducing or discontinuing MPA can increase the risk of acute rejection and may negatively affect long-term graft survival. Therefore, every decision to lower the dose must balance two competing priorities. On one side, we want to eliminate the toxicity, and on the other side, we must preserve adequate immunosuppression to protect the allograft. This is why MPA should rarely be stopped without a replacing strategy. Whenever possible, an alternative antimetabolite such as azathioprine should be introduced to maintain immunological protection. Another important consideration is that MPA is not the only immunosuppression drug capable of causing diarrhea. Tacrolimus can also contribute to gastrointestinal symptoms. However, in most transplant cohorts, MPA remains the most frequent culprit, especially when diarrhea is severe, chronic, and associated with weight loss. In our patient, the persistence of symptoms despite extensive evaluation, together with eventual resolution after MPA withdrawal, strongly support MPA as a primary cause. The biggest mistake in the management of MPA toxicity is focusing only on symptom control and forgetting the graft. Every reduction in immunosuppression carries a potential immunological cost. Never ask, can I stop MPA? And instead ask, how can I safely replace MPA while maintaining protection against rejection? This caution becomes even more relevant when we consider another intriguing feature of MPA toxicity. Why do some patients develop symptoms only many years after transplantation despite apparently tolerating the drug for a long time of follow-up? One of the most intriguing observations in the MPA literature is that not all MPA-related diarrhea appears to be the same disease. Early GI toxicity is often dose-dependent. Patients develop diarrhea shortly after transplantation, and symptoms frequently improve when the dose is reduced. Late-onset toxicity appear different. These patients may tolerate MPA for many years before suddenly developing severe diarrhea, substantial weight loss, malabsorption, and histological evidence of intestinal injury. This had led some investigators to propose that late-onset MPA enteropathy may represent distinct clinical entity rather than simply a delayed version of routine GI intolerance. Several observations support this concept. First, symptoms can emerge after years of stable dosing without any recent increase in drug exposure. Second, the patient often develops features of malabsorption and nutritional compromise that are unusual for simple medication intolerance. Third, histological abnormalities may resemble celiac disease, graft versus host disease, or inflammatory bowel disease rather than non-specific drug-related diarrhea. Importantly, these patients frequently don't respond adequately to modest dose reduction and often require complete withdrawal of MPA before symptoms resolve. Our patient fits many of these characteristics. 7 years after transplantation, she developed severe chronic diarrhea, weight loss, resistant symptoms despite a 50% dose reduction. This pattern is much more consistent with late-onset MPA enteropathy than the routine early GI toxicity. Think of MPA toxicity as a spectrum. At one end is simple dose-related diarrhea, at the other end is late-onset enterocolitis with mucosal injury, malabsorption, and weight loss. The delay between drug initiation and symptoms onset doesn't exclude drug toxicity. In some immune-mediated drug injuries, the latency period may extend for years. If late-onset MPA toxicity represents true intestinal injury, what exactly does the bowel look like under the microscope? The histopathology provides some of the strongest evidence that is more than simple diarrhea. One of the strongest arguments that late-onset MPA toxicity presents true intestinal injury comes from the histopathology. When biopsies are obtained from affected patients, the findings extend far beyond non-specific diarrhea. In the small intestine, investigators have reported varying degrees of villous atrophy. In some cases, the mucosa may closely resemble celiac disease with shortening or flattening of villi and evidence of malabsorptive injury. These changes help explain why some patients present with profound weight loss and nutritional evidence deficiencies. The colon can be equally striking. MPA colitis has been described as a great histological mimic because it appears may resemble several other diseases depending on the biopsy. Pathologists may consider Crohn's disease, ischemic colitis, or even graft versus host disease in the differential diagnosis. This overlap is one of why awareness of medication history is essential, and when interpreting biopsy results, perhaps the most characteristic finding is increased epithelial apoptosis. The crypt epithelium demonstrates apoptotic bodies, crypt injury, and sometimes crypt loss or architecture distortion. In more severe cases, crypt abscesses and crypt atrophy may also be present. These findings support the concept that MPA induced direct mucosal injury through extensive epithelial cell death. Taken together, villus atrophy, crypt injury, and apoptosis provide compelling evidence that severe MPA toxicity is a structural disease of intestine, not simply a functional side effect. When a transplant recipient develops chronic unexplained diarrhea, biopsy findings that resemble graft versus host disease, inflammatory bowel disease, or celiac disease should always prompt review of MPA exposure. The hallmark microscopic clue to MPA toxicity is increased crypt epithelial apoptosis. often accompanied by crypt dissolution and mucosal injury. Histology alone rarely establishes the diagnosis. The diagnosis emerges from combining pathology, medication exposure, exclusion of infection, and clinical improvement after MPA withdrawal. These histological findings arise an important mechanistic question. Why does inhibition of lymphocyte purine synthesis ultimately lead to epithelial injury, crypt apoptosis, and colitis? Although MPA-associated enterocolitis is now well recognized, the exact mechanism remains incompletely understood. That we know if that prolonged exposure to MPA can ultimately result in structural injury to the intestinal mucosa. The current model proposes a sequence of events. First, the intestine is exposed to MPA and it metabolites over an extended period. This exposure is followed by injury to the proliferating epithelial cells within the intestinal crypts. Histologically, this manifests as increased crypt apoptosis, one of the hallmark findings, as we mentioned. As crypt injury progresses, the regenerative capacity of mucosa becomes impaired. Over time, they can lead to villus atrophy, loss of absorptive surface area, and the development of malabsorption. Clinically, patients then persist with chronic diarrhea, weight loss, nutritional deficiencies, and volume depletion. An important point is that the exact drive of this process remains uncertain. Some investigators favor direct epithelial toxicity from MPA itself. Others propose an immune-mediated mechanism in which alteration in mucosal immune regulation trigger intestinal injury. It's also possible that both mechanisms contribute simultaneously. Interestingly, the pathogenesis of severe late-onset enterocolitis may differ from that of more common early dose-related diarrhea seen shortly after transplantation. This could explain why some patients with simple dose reduction improve, whereas others requires complete drug withdrawal. So not all MPA-related diarrhea is the same disease. Early diarrhea may be primary functional and dose-related, whereas later onset enterocolitis appear to involve true mucosal injury. The strongest evidence supporting the pathogenic role of MPA is not the biopsy alone, that combination of characteristic histology and subsequent clinical recovery after withdrawal of the drug. When you see crypt apoptosis plus villus atrophy in a transplant recipient receiving MPA, think beyond simple medication intolerance and consider MPA enterocolitis as a genuine tissue injury syndrome. If intestinal injury results from MPA exposure, the next logical question is who is the most vulnerable to developing this complication, and why do only certain patients become affected and symptomatic? One of the most interesting aspects of MPA-associated enterocolitis is that it's not restricted to kidney transplant recipient. Most published reports come from kidney transplantation simply because this population receive MPA more frequently and for longer duration. However, similar cases have been described across multiple clinical settings. Cases have been reported in liver transplant recipient, heart transplant recipient, and other solid organ transplant population. Importantly, the syndrome is not exclusive to transplantation. Patients receiving MMF for autoimmune disease, including lupus, systemic autoimmune disorders, have also developed the same pattern of severe diarrhea, weight loss, malabsorption, and characteristic histological finding. This observation suggests that the primary driver is exposure to MPA itself rather than the transplant organ. In other words, the disease appears to be drug-specific rather than transplant-specific. That being said, transplant recipient may be particularly vulnerable because of prolonged exposure, combination, immunosuppression, altered gut motility, and frequent concomitant medication and the low immunity. For the practicing nephrologist, the key message is simple. If the patient is receiving MPA and develop unexplained chronic diarrhea, this diagnosis could remain in the differential diagnosis of the underlying indication of therapy. MPA enterocolitis follows the drug, not the organ. Think of medication before you think of the transplant type. The fact that identical histological lesions occur in both transplant and autoimmune population strengthen that argument that MPA is the causative factor rather than an indirect consequence of transplantation. And lastly, many clinicians consider MPA toxicity only in kidney transplant patients. The literature suggests that this under-recognized complication across all patient groups exposed to longer-term MPA. If exposure alone were enough, every patient receiving MPA would develop diarrhea. The next question becomes, why do some patients develop severe toxicity while others tolerate the drug for years without any gastrointestinal symptoms? At first glance, it seems logical to assume that higher MPA levels should produce more GI toxicity. Surprisingly, the available evidence doesn't support that assumption. Several studies have failed to demonstrate consistent relationship between circulating MPA concentrations and the either occurrence or the severity of diarrhea. In other words, patients with therapeutic drug levels may develop severe enterocolitis, while others higher level remain completely asymptomatic. This observation suggests that systemic exposure alone doesn't explain the disease. and instead local intestinal factors may become more important than plasma concentration. Potentially contributors include direct mucosal exposure to MPA metabolites, individual susceptibility, alteration in gut microbiota, genetic differences in drug metabolism, and immune-mediated injury. The practical implication is extremely important. Normal MPA levels doesn't exclude MPA-induced enterocolitis. Likewise, therapeutic drug monitoring cannot reliably predict who will develop severe GI toxicity. Therefore, the diagnosis remains primarily clinical and supported by exclusion of alternative causes and improvement after drug withdrawal or substitution. Treat the patient, not the MPA level. GI toxicity can occur even when drug concentrations are perfectly therapeutic. This lack of correlation argue against simple dose-dependent toxicity and raise the possibility that late-onset MPA enterocolitis may represent a biologically distinct process involving host susceptibility and local intestinal injury. If a transplant recipient has chronic unexplained diarrhea, don't dismiss MPA toxicity simply because MPA trough level is within target range. A blood level don't explain toxicity. The logical next question is whether changing the formulation might help. But switching from conventional MMF to enteric-coated mycophenolate reduce GI symptoms while maintaining immunosuppression. This is a very common question. One proposed strategy for managing MPA-related toxicity is switching from conventional mycophenolate mofetil to MMF to enteric or MMF to enteric-coated mycophenolate sodium, commonly known as myfortic. The rationale seems attractive because the enteric-coated delays dissolution until the drug reaches the small intestine. Some clinicians hope that the gastrointestinal exposure toxicity may be reduced. Indeed, several case reports and small observational studies have described symptom improved after conversion to enteric-coated formulation. However, the biologic reason is not as strong as it first appears. Remember that both MMF and enteric-coated MPS are simply prodrugs of the same active compound, mycophenolic acid. Once absorbed, they generate the identical active metabolites. More importantly, the pathological lesions associated with MPA enterocolitis occur primarily in the small intestine and colon, precisely where enteric-coated formulations are designed to release the drug. For that reason, many experts wouldn't expect a dramatic reduction in toxicity for patients with established MPA enterocolitis. In patients with mild upper gastrointestinal intolerance, switching formulations may help. In patients with severe diarrhea, weight loss, malabsorption, or biopsy-proven MPA enterocolitis, complete withdrawal and substitution are usually more effective than simply changing formulations. Different formulations, same active drug, changing the delivery system doesn't necessarily eliminate the pathogenic exposure. If the patient is driven by local intestinal exposure to MPA, releasing the drug directly to the small intestine may not solve the problem and could theoretically maintain the same injury. Switching from MMF to myfortic may be reasonable for mild GI intolerance. For severe MPA enterocolitis, evidence generally favor drug discontinuation and substitution rather than formulation switching alone. This raises another important question. If both formulations produce the same active drug, why do only a minority of patients develop severe toxicity? Let's look at the factors that may increase susceptibility to MPA-induced gastrointestinal injury. These causes will be discussed in details in the second lecture, but once MPA-related gastrointestinal toxicity has been identified, management should be systematic and should always balance symptoms control against the risk of rejection. The first step usually is dose reduction. If the patient was mild or early post-transplant diarrhea, reducing MPA dose by approximately 50% may be sufficient to achieve symptom improvement while preserving the benefits of anti-metabolite therapy. However, severe or persistent cases often behave differently if symptoms continue despite dose reduction, particularly when accompanied by weight loss, malabsorption, histological evidence of MPA injury. Complete discontinuation of MPA should be considered. Importantly, discontinuation should rarely occur in isolation. As we mentioned, the preferred strategy is substitution rather than withdrawal. In most report cases, MPA was replaced with azathioprine, allowing maintenance of triple immunosuppression while removing the offending drug. This approach minimizes the risk of acute rejection while addressing the underlying cause of diarrhea. The ultimate goal is not simply to stop diarrhea. The goal is to maintain adequate immunosuppression, protect the allograft, improve the patient's quality of life at the same time. The mistake is not reducing MPA, the mistake is reducing immunosuppression without replacing it. Severe MPA toxicity is usually managed by substitution, not by immunosuppression withdrawal. So that was the algorithm to deal with such a patient. At this point, the obvious question becomes, why do typically switch to azathioprine? The answer is practical rather than theoretical. Azathioprine is established antimetabolite with decades of transplant experience and well understood safety profile. Most importantly, it works through completely different metabolic pathway than mycophenolate. As a result, it doesn't share the characteristic gastrointestinal toxicity that drives MPA associated enterocolitis and severe diarrhea. By replacing MPA with azathioprine, we can often preserve adequate immunosuppression while eliminating the offending drug. In other words, we solve the gastrointestinal problem without creating an immunological problem. This is particularly important in kidney and pancreas transplant recipient, where maintaining sufficient immunosuppression is critical to long-term graft survival. The objective is not to find stronger drug, the objective is to find a drug that the patient can actually tolerate. The best immunosuppression regimen is not the most potent one, it's the most effective regimen that the patient can safely tolerate long-term. Azathioprine remains one of the most useful rescue antimetabolites when MPA-related gastrointestinal toxicity develops. However, azathioprine is not a perfect substitute. Compared with MPA is generally associated with high rates of acute rejection in some transplant population. Therefore, the decision to switch must balance severity of GI toxicity, nutritional consequences, rejection risk, overall immunological profile of the recipient. One of the most important and frequently overlooked consequences of diarrhea in transplant recipient is its effect is on Tacrolimus exposure. Many clinicians assume that diarrhea decreases the drug exposure. With Tacrolimus, the opposite often occurs. Severe diarrhea can actually increase Tacrolimus bioavailability, leading to unexpectedly elevated trough levels. The mechanism is complex and involving disruption of intestinal metabolism and transport systems, particularly B-glycoprotein and CYP3A activity within the inflamed gut. As intestinal injury develops, first pass metabolism decrease, allowing a larger proportion of Tacrolimus to enter systemic circulation. The result is a rise in Tacrolimus levels despite no change in dose. In this patient, Tacrolimus trough concentration increased from approximately 7 to 13 during the diarrheal illness. This is not simply a lab observation, it's real clinical consequences. Elevated Tacrolimus exposure may contribute to nephrotoxicity, neurotoxicity, tremors, hypertension, hyperkalemia, worsening kidney function. Therefore, every transplant recipient with significant diarrhea should have close monitoring of Tacrolimus concentration. Failure to recognize this phenomenon may lead to clinician to misinterpret Tacrolimus toxicity as progressive of underlying disease. Diarrhea plus Tacrolimus often equals higher Tacrolimus levels, not lower levels. Any transplant recipient admitted with severe diarrhea should trigger an autonomic Tacrolimus levels check. Also, keep in mind that this is very important. Beyond Tacrolimus toxicity, coronary diarrhea itself can cause important metabolic hemodynamic complications that further threaten graft survival. While identifying the cause of diarrhea is important, we should never forget the physiological consequences of ongoing gastrointestinal fluid loss. In transplant recipient, coronary diarrhea is not merely a quality of life issue, it can directly threaten graft function. One of the earliest manifestations is volume depletion. Patient may develop orthostatic hypotension, dizziness, fatigue, and reduced renal perfusion. In this case, measurable systolic blood pressure drop on standing, suggesting significant volume contraction. As intravascular volume decreases, kidney perfusion falls, and serum creatinine begins to rise. Importantly, this increased creatinine may not represent rejection, recurrent disease, or CNI toxicity, sometimes simply represent azotemia caused by chronic fluid loss. Coronary diarrhea also causes characteristic electrolyte abnormalities. Loss of bicarbonate-rich intestinal fluid may produce normal iron metabolic acidosis. Patients frequently develop low serum bicarbonate concentration and may also develop potassium depletion. These abnormalities can contribute to fatigue, muscle weakness, worsening kidney function more if left untreated. Therefore, management of transplant-associated diarrhea must extend beyond identifying the cause. Clinician must simultaneously correct volume depletion, monitor renal profile, and replace ongoing electrolyte loss. So not every rise in creatinine in transplant recipient is rejection. Sometimes the kidney is simply asking for volume. Persistent diarrhea should trigger routine assessment of orthostatic blood pressure, weight trends, serum creatinine, bicarbonate, potassium, magnesium, and this is very important. Of course, MPA is not only medications capable of causing diarrhea in transplant recipient. Complete differential diagnosis must always include other drug-related causes as well. So at the end, I would like to thank you all for watching all this long lecture. The diagnosis, as we mentioned, is MPA-induced colitis and GI toxicity. The treatment was MMF discontinuation because this is a type 2 late-onset MMF-related toxicity, and the patient was switched to azathioprine, and the outcome was very good. Diarrhea resolved within weeks, weight regained within 1 month. Thank you so much for watching, and I would like to see you all in the next lecture. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.